Okay, guys. Uh, this will probably never happen again, but I had no sound in my tegrity during class, so I am going to quickly go over the high points of my notes. Um, you will still probably, if you missed class, you're still probably going to want to get class from um, uh, a colleague of yours. So we're talking about hemorrhagic disorders, and I recorded the mental health disorders and substance abuse um, just now. So bleeding in pregnancy is a huge deal. Um, it is a medical emergency. And so all of these things can happen if mom loses blood, which will affect both mom and baby. Okay, fetal risks. Then if mom has a hemorrhage, then baby will get hypoxic, obviously, go to hypoxemia, anoxia. We see preterm birth with maternal hemorrhage, and then of course anemia. Baby becomes anemic, not a good thing. We know that it's a medical emergency, and we have basically early and late trimester, early and late pregnancy bleeding. So early pregnancy, miscarriage, also known as spontaneous abortion. I will also call it AB, spontaneous AB. So we know that an abortion, miscarriage, is natural causes. The pregnancy ends before 20 weeks. And 10 to 15% of pregnancies end in miscarriage. The number is probably a lot higher, but a lot of times it happens very early, much earlier in pregnancy. Oops, I want to go back. And then some of the things that early we usually see because there was some chromosomal abnormalities. We also call that a blighted ovum. And also severe hypothyroidism. If they can get pregnant at all, if there is untreated hypothyroidism, they often will end in miscarriage. So uncontrolled diabetes is another one. Of course, early on, if it's uncontrolled, we also see genetic problems, so that would cause it. Chickenpox or varicella infection can cause an early miscarriage. Late miscarriage would be between 12 and 20 weeks. It's a second trimester loss. The reasons, usually alcohol use, excessive caffeine, morbid obesity. There can be a lot of different problems, accidents. So, and this is a cause of bleeding in the first trimester, obviously. So, okay. And then these are the 2 pages that you need to know for sure. A threatened abortion or threatened miscarriage is when you have some spotting and some mild cramping, but the cervix is closed. So if the cervix dilates, we know we're going to have a miscarriage, okay? But if the cervix is closed, we look at the cervix is closed, we can maybe stop it by, we'll talk about that in a minute. Inevitable is when an inevitable miscarriage is when the cervix has opened. Okay, so you have an open cervix, you have a rupture of membranes, the fetus is expelled. Usually there's heavy bleeding, and oftentimes beforehand you start having mild to severe cramping. Incomplete is the fetus is expelled, but the placenta is retained. So that's an incomplete abortion. Complete is everything comes out and the cervix is closed then after that, and you have some mild cramping and just some slight bleeding, and it's basically all over with. A missed abortion, there are no symptoms, but oftentimes this is caught on an ultrasound. There are no signs of life. There's no growing pregnancy. and then we have to induce that miscarriage. Recurrent miscarriages are 3 or more losses, and that's, of course, always before 20 weeks of gestation. Some people, for whatever reason, cannot carry a baby, and then they have recurrent miscarriages. Septic is uncommon. It's when there's a uterine infection, fever, abdominal pain. The abdomen will be very tender. There may be some bleeding, and then a very foul odor. We have an infection, and we need to get the products of conception out then. And so A is a threatened abortion. B is inevitable. You can see the cervix is open. C, there's, oh, here I should be doing this. C, so the cervix is open here. C is incomplete. You can see the cord and the placenta are still left in there. And then this is supposed to be everything is out, so this would be complete. There's the placenta and the sac and everything. And then this is a missed abortion. So you have the fetus or the embryo, whatever, in there, but it has passed. There's no signs of life. Okay, so look at table 28-1, page 671 for miscarriage assessment and management, for sure. And then miscarriage care management. We're going to look at the history, obviously, check vital signs. You know, we want to know if mom is having hypovolemic shock. We look at the quantity and the nature of the bleeding. Is it bright red blood? Is it dark? Talk about the pain and how much pain. We're probably going to get a CBC. We want to know the hemoglobin, hematocrit, platelets, white count, for sure. And then depending upon what kind of miscarriage, it is dependent upon what kind of care we'll give. Expectant management means this would be for a threatened abortion. And this expectant management, remember this for later on, expectant management is bed rest. Bed rest with bathroom privileges, maybe bed rest with a just using a bedpan, complete bed rest. We'll be watching closely, ultrasound, doing labs, all right? Medical management for like a missed abortion or incomplete abortion would be misoprostol or Cytotec. Cytotec, it's a stomach drug, but we use it to make the uterus cramp, and hopefully it will cramp, and then after you've had that, the cervix will dilate, and then it will expel the products of conception. Okay. And usually after the oral meds, it's done in 7 days. Everything is gone. Surgical management is a D and C, dilatation and curettage, and that's when we have to go in and clean out the uterus, scrape the walls of the uterus, make sure everything's out. And so depending upon how acute, if there's a lot of bleeding, we would probably go in and do a DNC before we would use the misoprostol. And moms kind of have a choice there. They really, you know, if they don't want to wait 7 days, they would just want it all over with, they can come in an afternoon. The thing about surgical management is it's higher risk because you've got anesthesia, you're actually doing a procedure. So, but oftentimes we leave the decision to mom. Oops. Also, then we have to be sure that we're assessing mom's grief. This is a pregnancy loss. Follow-up phone calls to check on mom, refer to support groups or counseling, whatever. I want you to read Discharge Teaching Box on page 672. Okay. Most of the time, though, miscarriage will, you know, be spontaneous and will be done right away. And some moms don't even know they're having a miscarriage. If they didn't know that they were pregnant, they may just have a later, heavier period. And so that's why the number could be much higher. Okay, cervical insufficiency. Because of whatever reason, this would be a later miscarriage, later in the pregnancy, probably second trimester. You may have, it doesn't hurt. You're not having cramping or contractions. You just have a really weak cervix, and it opens up and dilates. It could be because of a birth defect, some kind of abnormality in the uterus, or it could be some kind of cervical injury, or if mom has had a procedure on the cervix, like taking part of the cervix off for like a cone biopsy for HPV cancer. And some women have shorter cervixes, which is why they can have an incompetent cervix. One thing that they're starting to do now is to measure cervixes through pregnancy to see if there could be a causal relationship between preterm labor and a short cervix, but we know you have a better chance as that pregnancy grows of, if you have a cervical insufficiency, for it to open up and then lose the baby. Diagnosis: will take a speculum, look to see what's going on, do transvaginal ultrasounds, okay? Sometimes we will actually have an opening and the fetal membranes will start coming through the cervix. If that's the case, we'll try to put mom up in Trendelenburg to get it to go back in, and then maybe sew up the cervix, and we'll talk about that in a sec. Care management would be a cerclage, and that's sewing up the cervix. It can be, we can do it early on, prophylactically, if mom has had a history of miscarriages for incompetent cervix, or as a rescue procedure. If mom is early and we've noticed that her cervix is shorter, we will do that to save, make sure save that pregnancy. Once we have it in, we take it out at 36 weeks gestation. Usually we'll place it between 14 and 23 weeks, and then a rescue would be between 16 and 23 weeks. How do we know we're going to need to do it prophylactically? By ultrasound and by history. And then we take those sutures out by 36 weeks of gestation. And then after that, if mom has cramping, low backache, she needs to come in. Those are signs of preterm labor. And then if she goes into preterm labor, and we can't stop it, we will remove the sutures. And so obviously, if you have this, you always have an increased chance of losing the baby. And so be sure to teach mom the signs to watch for: preterm labor, rupture of membranes, any signs of infection. So we have a couple of different procedures. This is the most common cerclage. They basically sew it up and pull it together per string suture. Or they can go in intra-abdominally and actually do an intra-abdominal closure of that cervix. If that's the case, they have to have a C-section. And the picture for that is on 675, figure 28-3. So, and that is the case of a really, really short cervix. And usually they know that beforehand. Another reason that we have early pregnancy bleeding, and this is an ectopic pregnancy, and it's implanted outside the uterus. Most of the time in the fallopian tubes or uterine tubes, so they're called tubal pregnancies, but they can implant anywhere. So you can see this anywhere: tube, ovary, outside, into the abdomen, on the omentum, and then we would see that late. Then ovarian, like I said, cervical. A lot of times if a woman has had a history of a C-section, it will implant in the C-section incision in the uterus. So we see this probably 1 to 2% of first trimester pregnancies. So the biggest risk and the cause of maternal death for this is maternal hemorrhage. And that's the biggest concern. That's what we see. They happen because of maybe pelvic inflammatory disease, so a history of sexually transmitted infections, any kind of scarring that has gone on from endometriosis, prior IUD use, tubal ligation can change where that ovum will actually, fertilized ovum will implant, okay? If you have had this and you have to, they have to remove it, it will cause scar tissue. It's a leading cause of infertility, oftentimes because they have to take out one tube, and so it cuts your chances of conceiving for about 50%. So that tends to be a pretty common deal. Let's see. Usually after 6 to 8 weeks after the last normal menstrual period. And then these are the 3 classic symptoms you need to know. The abdominal pain will start as mild, but then gets constant and severe. They may have a little bleeding from in 1 to 2 weeks, and it'll just be kind of a light spotting instead of a full menses. And then then that spotting will be mild to moderate with old blood. It's not going to be fresh, bright red blood. It will be dark brown. Excuse me. So, and we saw that. So for ectopic pregnancies or tubal pregnancies, to diagnose it, it can look like a lot of other things. Like it can look like appendicitis. That's one that you would often think of. So when physicians, especially in the emergency room, because that's where they see this, or in the clinic, are going to always rule out pregnancy if there's some kind of abdominal symptom. So just like before surgery, a woman of childbearing age will get a pregnancy test. They must always consider in diagnosis and rule out an ectopic pregnancy. So mom is guilty with an ectopic pregnancy until we prove her innocent. So they have to get a positive pregnancy test, and then they would do an ultrasound. So what would they see on that ultrasound? They're not going to see a fetus in the uterus, which is what we would expect. If the tube actually ruptures, mom will go from having that constant severe abdominal pain to pain in the shoulder from having blood in the abdominal cavity. That's referred pain. And then signs of shock, even if there's no bleeding. And oftentimes there's not, because you're bleeding into the abdomen, depending. There might not be a whole lot of bright red bleeding vaginally. Mom gets shocky, faint, dizzy. She may get the Cullen sign, which is like bruising around the umbilicus. And so another thing that they'll look at to help diagnose are the quantitative HCG levels. If looking at pregnancy, we would see elevated early in pregnancy, okay, but there would be no fetus on the ultrasound. And they'll check out progesterone levels too. Okay, so how do we manage this? Theoretically, you could do surgery and remove that pregnancy products of conception from the tube, but it's really, really easy to damage that delicate tube. So usually they have to take the tube out, and they can't just leave it. Methotrexate is a chemotherapeutic drug. They use it as an anti-inflammatory for asthma and for arthritis. But if you take it, it will dissolve the pregnancy in 2 to 8 weeks. At the same time, when we're giving that, we're going to check the HCG levels, because that pregnancy will then, of course, die. And we want to make sure the HCG levels go down. So we'll have mom in weekly to do that. You can give methotrexate orally or IM. And then we want preconception counseling, obviously, because ectopic pregnancy can definitely reoccur. We need to teach them about infection, bleeding, any signs of problems, so that they can check back in. Okay, hydatiform mole or molar pregnancy is a weird kind of trophoblastic disease. It's this. It originates in the placenta. It grows weirdly. The chorionic villi become cysts and vesicles. They're filled with fluid, hang in clusters, and it's not a viable pregnancy. There's no fetus growing in there, but mom will have a positive pregnancy test. They think it's caused by abnormal fertilization. Okay. And I did have a friend who had that. Let's see. So there are 2 types of hydatiform mole: the complete, where there was no real any part of a fetus growing, and then partial may have some fetal parts, teeth, hair, or an amniotic sac inside these. And you can see, if you look closely, there's little grape-like clusters, and the whole uterus was totally full of them. So it's kind of gross. So this can cause bleeding. It might be a while. So it can be early pregnancy bleeding or late pregnancy bleeding. It may be a while before we actually diagnose it. So some of the signs that we see, mom may have some intermittent bleeding going on. All right. And we see much higher HCG levels. Those hormones go crazy. So what could that be? When we see that hyperemesis gravidarum, it could be a multiple pregnancy. It could be, having twins or triplets or quads. The uterus usually measures large. Again, that could be because you're having a multi-fetal pregnancy. Later on, preeclampsia is very common. Normally, we'll get some kind of an ultrasound. You're not going to hear, by the time we get to 12 weeks and you can't hear a heartbeat yet, they'll probably get an ultrasound and they'll check that, and there will be no fetus. There's really no pregnancy. It's still a major loss for mom, still that loss of the thought of the baby, the thought of that pregnancy. So mom needs to be watched very carefully. Care management section, curettage, so they go in and clean out the uterus with using some strong suction. All right. Let's see. And normally we would think serum HCG levels would, they normally go up, and then at a certain point the placenta takes over putting out those, or supporting the pregnancy, and HCG levels start dropping. If in a molar pregnancy, they'll keep going up. So you can see if somebody has this and they're not seeking prenatal care, this could go on for quite a while. Let's see. They need lots of education. if we're doing follow-up. Lots of support with loss support too. The follow-up is long. It lasts a whole year. They have to have weekly HCG levels for 6 months and then monthly for another 6 months. Molar pregnancies can reoccur. My friend who had one had it in her first pregnancy and then had it in her first pregnancy and then ended up having 2 normal pregnancies after that. So, and there is a correlation of cancer and molar pregnancies together. Another very common reason for late pregnancy bleeding is a placenta previa. Some of this could be early or late. There's a table on 28-2 on page 680. It talks about our next 2 topics, placenta previa and placental abruption, so you might want to look at that. And this is just means that instead of implanting, the placenta implants, instead of implanting in the fundus where we want up high, it implants low on the lower, softer uterine segment, and it can totally cover the cervical os, or it can just, part of it can be over the cervical os, or it could just be close to the cervical os. So, so that's what those are. And here's the pictures. So this is a complete placenta previa. You can see here's the cervix, and note that there, as if the cervix starts opening up, it's tearing away the placenta, all those teeny little capillaries and vessels, and you will have massive amounts of bleeding once that cervix starts to dilate. This is a low-lying placenta. If we have any kind of cervical dilatation, you will have some bleeding there too. Either can be serious. It's pretty common, 1 in every 200 pregnancies. The definition, painless, bright red vaginal bleeding. It does not hurt to have a placenta previa. During 2nd or 3rd trimesters, when we really notice it, if that cervix is disturbed at all or open at all, then you will have some spotting. The major problem is hemorrhage. If mom hemorrhages, it can affect the baby. You can have a stillborn, or because of that, we have to take the baby because of bleeding, and the baby may be too early to live outside the womb. And then you can have all of these different things. Malpresentation means that the baby's not head down, and obviously if we expect the placenta to be up in the fundus, it can kind of turn that baby like it's not supposed to be. They will lose blood quickly if they have this, and if they can't stop the bleeding, taking the baby out and taking the placenta out, they may have to have a hysterectomy. Okay. So we see this in older women. We see this in women who have had many pregnancies. Let's see. You diagnose it by ultrasound exam. So if you have painless red bleeding, you get an ultrasound to diagnose placenta previa. Let's see. We would deliver most of the time. If they were bleeding from a placenta previa, we would deliver by C-section, or we may do expectant management, which again, observation, bed rest. We will, if the bleeding has stopped, we can do that. Put them in the hospital. They can't have any labor. By 36 weeks, we will deliver, because if the patient goes into labor, they can hemorrhage. So we don't want that. These moms are at a higher risk for postpartum hemorrhage also. Eventually, they might be able to go home on bed rest. If that's the case, they would need home health nurses in on them. They would need fetal monitoring at home and social services to coordinate all that. So if the bleeding stops, bed rest, have them do a pad count. We may, if the baby's early, between 24 and 36 weeks, we may give them magnesium sulfate to mature the neural system more quickly. And then pelvic rest, nothing in the vagina, and then ultrasounds and NSTs to make sure that the fetus is doing okay, and to watch that placenta. If the placenta is low lying early in the pregnancy, as the uterus grows, it may actually move up. Obviously, the placenta doesn't relocate, but by the fact that the uterus is growing, it goes up higher, farther away from the cervix. And then sometimes, if that's the case, mom might be able to deliver vaginally. Okay. All right, so the next thing that we're going to talk about, premature separation of the placenta, abruptio placentae, placental abruption. All of those are ways that we talk about that. It is the detachment of a placenta after 20 weeks. It's fairly common, 1 in 75 to 1 in 226. If mom has any kind of hypertension, pre-gestational, gestational, preeclampsia, this is a risk factor. Grade 1, 2, and 3, mild, moderate, and severe. And we grade them by ultrasound. Let's see. This is a sudden onset of intense pain, usually in that local place where the placenta has torn away. You may have, it may be with or without vaginal bleeding. The vaginal bleeding would be bright red. Mom will have a stiff board-like abdomen. It'll be very rigid. Fetal heart rate would be show signs of stress, because if a large part of the placenta goes away, we decrease perfusion, which means that the baby might have trouble. When you have that board-like abdomen, you actually see the fundal height rise, especially if it's filling with blood. And then the cuvulaire uterus is if there's a lot of blood trapped between the placenta and the wall. It's like a big, big bruise. And if it's that bruise happens enough on the uterus, it actually will decrease its ability to contract. And so you would just keep having blood loss, and we would have to do a hysterectomy. So if it's trapped, if it's an incomplete concealed hemorrhage, you have that rigid abdomen, but you also would see, even if there's some blood loss, you would see shock symptoms that are not in proportion to the amount of blood that you're seeing vaginally, okay? And when you see that, this is like a concealed one. So it tore right in the middle, so you have no vaginal bleeding at all there. Partial, if it tears and there's an end, you will have hemorrhage, you'll have vaginal bleeding. It can be completely separated, but still be hidden. This will be massive. The baby will not have any heart tones. The baby will have died, and there's no vaginal bleeding. Mom is going to be in extreme pain, board-like abdomen, increased fundal height, all that kind of stuff. And she will be shocky, most likely. Okay. Clinical manifestations, like we said, partial, complete, or marginal. It depends how mom and, oh, wait. I feel like I'm in the wrong spot here. Hold on. Yeah. Oh, I'm sorry. I spoke ahead. Should have been on this slide. I apologize. Okay. So maternal fetal outcomes depends upon the severity. They can survive a mild, a severe, probably 100% fetal mortality 80% mom mortality. It can be very, very serious. If they don't get in and we don't diagnose it right away, mom can bleed to death very, very quickly. So to diagnose, we'll do an ultrasound, although you can, just by the physical assessment sometimes, we are not going to stop to do labs and clotting studies, all those kind of things. If she's got a hard board-like abdomen and any kind of bleeding, we're going to get her back into the section room and to deliver that baby, no matter how old the baby is, and to stop the bleeding so mom doesn't die. Expectant management would be if the bleeding stops and it's just a little partial abruption, we'll just keep mom, do expectant management, keep her on bed rest, do NSTs, make sure, do ultrasounds. We're watching that baby very, very closely and watching for bleeding. And then anytime you lose part of the placenta, you have decreased perfusion. What do you have? Intrauterine growth restriction. So, and then again, if it's an active, massive placental abruption, we're going to have to do a C-section delivery, and we may end up doing a hysterectomy. It's a terrible thing. Okay. Not going to do, this isn't going to be on the exam. Sometimes the cord will go in certain weird places. Vasoprevia, battledore, insertion of the cord. You can have fetal and maternal hemorrhage from this. It's not going to be on the exam. It's all on page 684. But a vasoprevia, like you can see, these are the membranes. Here's the placenta. Normally, the cord would be inserted here, but it's not. It's in the membranes. So these are very weak, can cause premature rupture of membranes, fetal blood loss, decreased perfusion for sure. And these are the blood vessels and this is the cord then. So not an awesome deal. And then these are just, again, not on the exam. You can see vasoprevia, succinturate, and yeah. And it just increases the chance of hemorrhage if it's not inserted in the right place, which obviously is bad for mom, bad for baby. We know that pregnancy is a time of hypercoagulation. It's a very delicate balance. We want to protect mom from hemorrhage by clotting quickly, but at some times mom can have clotting problems. The biggest one is disseminated intravascular coagulation. This, remember, we have this. It's because of something traumatic that happens, whether it be preeclampsia, HELLP syndrome, sepsis, an abruption. It triggers the clotting cascade. So all of a sudden you have all of these little clots everywhere, and then the clotting factors get used up because they're trying to get rid of those clots. And then all of a sudden mom will bleed. Okay, widespread bleeding, external, internal, both. It's a terrible thing. Mom can die. Clinical manifestations are on page 685, box 28-2. Okay, and talks about some labs there too, which is kind of interesting. And care management for this, nursing interventions, you have to correct the underlying cause. So if mom has hypovolemic shock from bleeding or sepsis or preeclampsia, you got to fix that while taking care of this. We would give volume expanders, whole blood, obviously clotting factors because she doesn't have any anymore. We're going to support her breathing. We may intubate her. We'll give fresh frozen plasma, fibrinogen, vitamin K. Okay, all these things to try to, it's an intense emergency. The We have to watch for renal failure, multi-system failure, and, you know, emotional support. It's a scary thing. Keep her warm. All of these things when you have DIC. There's definite danger of death with DIC. In caring for an immediate postpartum woman, you note petechiae and oozing from IV site. You monitor closely for which disorder, disseminated intravascular coagulation. So there you go. Hopefully you can hear this time. I'll try to delete the other one, and have a good day.